Good evening, everyone, and welcome to this virtual webinar, which we believe will be of great value to you all. We are extremely delighted to have two prominent guests joining us tonight who will shed light on important topics relevant to all of us and to you as well. The main focus of tonight's presentation is how COVID-19 will be impacting us in respect of the future rollout plans for National Health Insurance, NHI. We will be looking at the lessons we've learned so far, as well as the challenges which lie ahead that we need to be on the lookout for. At this point, I would like to extend a warm welcome to Professor Alex van den Heever and Dr. Anban Pillay, who have graciously accepted the challenge to join us tonight. We are looking forward to robust debate following their presentations. I want to assure both of these preeminent speakers that we value their work and their insights on NHI, and it is a privilege to have them with us tonight. Of course, an event such as this cannot go without a bit of marketing. So I'd like to urge all of you who are not yet SALMA members to please visit our website or contact us on 012-481-2071 to find out more about joining our important association. There's a number on your screens which you can also use to get in touch with us to find out about the many benefits and services we offer to enhance your lives as doctors. Before we get into the presentations, I'd like to set a few ground rules. Firstly, I'd like to ask all participants to mute their microphones to avoid interference with the speakers, as well as your cameras. Secondly, please do not raise your hand or make use of the chat function, as we are unable to respond to questions raised during the presentations on the chat. Questions can be asked afterwards, and this process will be moderated by Mrs. Shelley McGee after both presentations. National Health Insurance, or NHI, is something which is going to impact on each and every one of us every day once.
Seems like we've lost Dr. Kutsia there. We'll try and get her back. We're trying to get Dr. Kutsia back. Just give it a minute. We're back now. Dr. Kutsia is just trying to log in again, and then we can carry on.
Good evening again. I'm so sorry. One moment I was still with you, and the next moment I were gone. I'm not sure till where did you hurt me. So I am going to start introducing our speakers for tonight, and I'm extremely sorry for what happened. So just to make sure that we all understand that we cannot ignore the fact that COVID-19 has highlighted several weaknesses in our health system. Weaknesses we need to acknowledge and jointly find solutions for. We must be cognizant of the fact that it's not only up to government and policymakers to make NHI work. NHI can only be effective if we all work together. So tonight, we will certainly learn how COVID-19 has impacted on the implementation of NHI, the way forward for NHI, and our roles in ensuring its success. Now, on to our speakers. Dr. Anban Pillay is currently the Deputy Director General of Health, Regulation and Compliance at the National Department of Health. And I'm sure he doesn't need any introduction because he's very well known. Dr. Anban is also a member of the Council of Medical Schemes, sits on the Global Fund Expert Advisory Committee and the UNICEF Gavi Expert Advisory Committee. In addition to all of this, Dr. Anban is an honorary senior lecturer at the University of KwaZulu-Natal. Dr. Pillay's research focuses on drug utilization, knowledge, attitude and behavior of prescribers, drug selection by pharmacy and therapeutic committees, meta-analysis and systemic reviews, and cost-effective analysis. He earned his PhD from the University of Newcastle, Australia, and also holds a Master of Clinical Pharmacology from the Nelson Mandela School of Medicine and a Bachelor's of Pharmacy from the University of KwaZulu-Natal. On that note, Dr. Pillay, over to you for your presentation, which we have all been waiting for. Thank you so much.
Good evening, Dr. Coetzee, and good evening to all the panelists, as well as to those that are participating, the participants in this evening's webinar. Thank you for the invitation, and I think this is a very useful topic to be talking about at this stage. I focused my presentation largely on our COVID response, and I think the lessons that the COVID response has provided us with so that we can adjust our NHI response according to the lessons that we've learned. I hope you can see my my screen at this stage.
Yes,
we can.
You can, good, okay. If I can then go through my presentation. The outline of the presentation is basically to look at the epidemiological profile, a snapshot of what's happened, some of the governance structures that we have in place, so you have a sense about what's happening from that perspective, our COVID-19 health sector response, some of the non-pharmaceutical interventions and our thinking around that, what has been our response to over time. We're currently in a period where we're anticipating a resurgence, and what are we thinking about that? And then to close up with what does all of this tell us about what we need to think about in terms of NHI? So I think that's probably the overview of my presentation today. So if I can just go through a snapshot, this is the global picture around the pandemic at this stage. As you can see, the Americas continues to dominate in terms of the case fatalities being the highest, and I think that's largely driven by what's happening in the US. Globally, case fatalities around 2.6. You can see that the SADC region is around 2.6, which is a global average, and there are a number of countries that are below that. I think Southeast Asia is most noticeable in terms of the low case fatality rates. And that's, I think, largely driven by the interventions that have been put in place and the behavioral change that they've been able to achieve. If we look closer to home on the continent itself within the African region, what you notice is that South Africa is clearly one of the highest has the highest case fatality ratio, as well as number of cases. Egypt very close to us, as well as Ethiopia, and then Nigeria, and then Libya. I think it's also important to make the point that many of the cases, as well as the fatality rates, are linked to the capacity and the resources available in countries across the continent to be able to do testing. So clearly our limitations around testing capacity will influence the number of cases that are confirmed in a country, as well as the mortality linked to that as well. If we go to the next slide, just trying to move on. Sorry, 1 second. Yeah. So if we go to the South Africa's epidemiological surveillance response, if we look at a closer to this time point, we can see that the cumulative number of cases reported on the 2nd of November was around 727,000, which was about a 0.1% increase from the previous day. We've had a national cumulative number of recoveries, which have increased by about 0.3% overall. After we've come out of the first wave, the average total number of daily tests confirmed averaged around 1,371, and we've been hovering in that range for a long time now. You also see that the cumulative number of tests that have been done is about 4.8 million that have been performed. The private sector is continuing to do a lot more tests than in the public system, which is something we're trying to scale up in the public sector. The national case fatality ratio is at 2.7%, and it seems to be sticking at that level for a long time now. These are the 7-day moving average of new cases by province that has been reported, and you can see the pictures are very much the same. The Gauteng province has had the highest peak, as you can see, but most of them have generally flattened off, and this is where we are currently. KZN, which is in green, you see, has also had a fairly large peak relative to the others, and the Eastern Cape as well, and Western Cape had earlier on started off with the epidemic, as we may recall. All of the other provinces had much lower levels of infection from the number of tests that were done. If we're looking at deaths, a very similar picture. The blue shading reflects the cumulative deaths, whereas the red line reflects our new deaths and on a 7-day average. You can see we're very much on the downward spiral. We do get some spikes now and then, but by and large we're on a downward spiral, but not not at the levels that we were in the beginning in March and April, but certainly well below where we were when we were having our surge. If we look at the cumulative as well as daily new cases, similar picture as the previous graphs. I think this is just another graphical depiction. Ideally, we'd want this to come down. As I was saying, we were hovering in this range for a long time now, and it does worry one as to whether this is actually going to develop into a second wave or not. These are the number of cumulative tests as well as daily new tests that are being done. And this is a graphical depiction of that. The tests have also declined. The argument out of my many centers is that people are not presenting for tests, and so that's a consequence of the decline. But I do think we need to try much harder to find those cases clearly that are out there in the community. The hospitalization trend has followed very much all the other trends, although it hasn't fallen off as much in terms of the hospitalization trends, if you see over the period relative to what we were in the beginning around May. This is an evolution of where we started and where we are now. On the 5th of March, on the 5th of March, we had our first case reported. You recall the family from the skiing trip in Italy, and that developed. And around the end of March, we then started our alert level 5, and that then progressed to alert level 4. We had between that period a community screening program. We then moved from alert level 4 to alert level 3. And then we started opening up some of the services. At level 3, we had our peak actually, as you can see here, and then we moved to level 2 at the 18th, and we're at level 1 currently on the 21st of August. This is just a timeline depiction of the same graphic. It has all of the detail in terms of what has happened over time. We often forget some of these, and so I thought it was good to include it. I'm happy to share the slides, which you may use for references. I think the next area which is important to talk about is the governance structures. And our COVID response has largely been a nationally driven response and implemented clearly at a local level through provincial departments. Very quickly after the understanding that we have an outbreak, the president established the NCCC, which is largely made up of ministers of cabinet. The Minister of Health and the Director General participate in the NCCC. There is, in addition to that, a ministerial advisory committee that provides advice to the minister and the department. But the NCCC has often also engaged with the ministerial advisory committee directly, with presentations to the cabinet itself without minister having to do that presentation, and so they engage with the MAC directly. The government had organized itself through the NatJoint structure, and this NatJoint structure is intended to bring together all of government to respond to this. This has been a structure that's been in place over years. It worked very well for the 2010 World Cup and brings together various sectors of government. Within the department, we have a structure referred to as the IMT, and the IMT structure is intended to bring together a number of work streams, which I'll talk about just now, that try to consolidate the health response as such, bringing as well the provincial departments of health along in developing a response to COVID. And it links into the NatJoints as well, where other government departments need to work in terms of this. So the functional groups that we've developed within the IMT are governance, leadership and coordination stream, logistics, medicines, PPE and other medical supplies, facility readiness, the quarantine sites, isolation, case management and EMS, then a port health. We had to plan for mortuaries as well in case we had the kind of deaths that were predicted, as well as planning for burial sites as well if we ever got there. Thank God we didn't. Information systems, so that we have a better handle on what's happening rather than the paper-based systems that were often available in some provinces when we started. Risk communication and community engagement. a critical issue to try and get behavior change going, because this is not about regulating behavior, but about trying to communicate the risks and getting the community to understand and change behavior. Human resources planning in terms of our facilities, understanding where we need additional nurses, the skills required to work in an ICU, and the clinicians that would be able to support that. And then the occupational health and safety stream, which largely deals with the workplace issues, and to support that as well, so that when the economy opens, we're able to deal with that. So specifically looking at the health sector, we developed a health response, and this is highlighted in the national plan relating to the health sector response. And the idea was, we knew we could never eradicate the outbreak, and the plan was always to halt the transmission, reduce its transmission, and minimize the impact on health and well-being of society, so that we can coexist together with the virus. And that's what we continue to try to do until we able to actually successfully get a vaccine in place. And so this plan is largely linked to a differentiated approach. And the first stage was really to prepare community education, capacity building, and surveillance. We then moved to a second stage, which was primary prevention, advising people around social distancing, reduced gatherings and border closures. There was then the lockdown, the more severe form of restriction in terms of curtailment of human interaction, surveillance and active case finding, and then looking at hotspots identification and timeous intervention, focusing on the provision of quality medical care once we got to the stage where we had high levels of infection and hospitalization. Also the bereavement and managing the psychological and social impact on our healthcare workers and families that have lost loved ones. And finally, to look at the ongoing vigilance, monitoring of antibody levels, and vaccine actions to see if how soon we can get a vaccine and prepare for that, as well as the ongoing vigilance which we are in currently, so that we can prevent a resurgence. In terms of our non-pharmaceutical interventions, we had a toolbox, as Professor Karim would like to describe it, of the interventions from social distancing to lockdowns to hand hygiene to symptom screening, use of cloth masks, the appropriate PPE, testing, isolation, quarantine, as well as the frequent environmental cleaning. I think these are the key interventions that we had implemented, and in each stage of the outbreak, we had to use a combination of these interventions in order to address the response. These actions at a very high level describe the way we thought about it. There was a period when we were managing the containment as such. We then moved to mitigation and then recovery. Under containment, we're largely looking at minimizing transmission as much as we could, to prepare for future health needs, whether those are hospital beds and space within facilities, the logistics, getting medicines and other things in place in case we need those high volumes, and then preparing the health workforce for that. Identifying the essential services to maintain the service delivery, patient flow, the triaging, and how you'd manage that at a facility level. Also providing the best information and best practice to a health workforce, particularly in terms of clinical management, etc. In our mitigation level, once you have a surge in place, you're no longer talking about containment, but more about mitigation and decanting your mild patients from your hospitals, using evidence-based innovative solutions such as high flow nasal oxygen, some of the things we've done and which have been very successful, extensive healthcare worker support, the rapid response teams, etc. And then now we're in the recovery phase. I think we're largely in a vigilant phase at this stage. We need to adjust our measures in line with the lockdown and just identify an alternative approach to outbreaks that may occur in particular areas, as Professor Karim would call them, the little fires that arise. So our response over time has been, to start with the non-pharmaceutical interventions. We then moved to the intense lockdown. We defined in the testing strategy. We also moved to from passive testing to active screening. We increased the number of cases, the case definition of who could have access. We ramped up our bed capacity, oxygen, ventilator production, etc. We also established field hospitals. And then now we're at the stage where we can even do antigen testing, as we have rapid antigen test kits available. So in terms of our plan to mitigate and respond to the resurgence, which is where we are currently, so we've developed a resurgence plan, which we hope will respond to the potential risk of a resurgence or the small fires as they develop, hoping that if we are able to respond to these small fires effectively, they don't become into larger bushfires and spread more widely that require us to take more drastic measures. And so what we've done in terms of this plan is identify a number of monitoring indicators that give us the first sign of a problem. These include the number of new COVID cases per day, the testing rate and per unit population, so that we increase the number of tests, particularly in areas that are lagging behind, because we may be missing cases and we may then end up with finding out there's a large fire in a place that we could have dealt with earlier. The percentage positivity rate, active cases, hospitalizations, mortality, as well as the all-cause mortality. So these are the indicators that we're using to identify areas that are at highest risk of resurgence. So we work with our provincial colleagues to try and prevent this from spreading. We use these as cutoffs currently. If it's less than 10%, we're looking at under control. Between 10 and 20, it's an alert, and over 20% increase in the preceding 7 days. We're requiring some very definitive additional action because the current measures probably in that area is not working. So the criteria that we're looking at is, as I indicated, the new cases, testing rate, positivity rates, and active cases, hospitalizations, etc. And we want to get right down to the ward and sub-district level, because often these are localized cases, and if we can catch them early in the localized area, we prevent them from spreading further. And that's, I think, the real game. So I think in this determination will have to be made with the support of an expert committee to provide advice, and then this declaration will have to be made with the minister in collaboration with the provincial counterparts. It's important that the provincial colleagues are part of this so that they very clearly understand where the risks are, and our failure to respond effectively to a risk does mean we would need to take more drastic measures in that particular area. We've identified a range of interventions linked to the areas I had described earlier. I'm not going to provide too much detail around this, but there's a whole document that goes into a lot of detail about what should happen at every level in terms of this. So the basic resurgence plan is to track the indicators. Once you detect an area that, whether it's a ward or a sub-district, identify and implement the interventions, continuously monitor and evaluate, report and feedback. So very simple, basic steps. But if we get this right, we don't need to go into any other levels of limitations and restrictions, because this is the key probably to reducing the level of infection in any area, and that will prevent us from getting into a surge. So how does this all fit in with our lessons for the NHI? I think one of the things that we learned through the process is that the COVID response was largely led at a national level, with Cabinet playing a key leadership role in guiding the response. And we could see that response provided a very useful approach to how we should manage these kinds of policies. At the provincial level, the provinces were largely responsible for implementation. They were at a national level, we had the NAT joints. At a provincial level, we had the Prof joints, and that worked very effectively in trying to coordinate policy together with implementation. in a number of areas. I think there were more successes than there were failures. And this is certainly a lesson in how we could have a better governance structure around managing our approach. I think secondly, we used a lot of expert committees in various areas, whether it's epidemiology or public health interventions or lab policies or behavioral sciences, vaccines and clinical practice guidelines. And the key principle, I think, here is that evidence-based decision-making is the most important principle that should guide leadership and the governance and policies that we come up with. And so I think that's an important learning. It's I think, appreciation from everyone at the leadership level that in bringing in the evidence-based decision-making is important, because it's an approach that can help everyone understand why we're taking a particular path. Where the evidence exists, obviously. In some cases, we obviously didn't have evidence for things, and we had to go with what we would consider to be the best considered approach. In the case of medicines and health products, we convened the pharmaceutical sector early in the pandemic. We anticipated that we may have problems, and I think that really helped because we asked them to stockpile, and a number of products became available relative to other countries that we had shortages, because not only is there a problem in terms of the production of accessing the API, but just the trade routes, the shipping routes, and the air cargo had been affected very significantly. And so I think we were spared. I mean, we did have shortages of some medicines, but by and large, we were spared the negative impact. And I think here, SAHPRA also played a very important role in responding to the urgency. I think they've understood that in the regulatory response, there is the usual regulatory response, and sometimes the regulatory response needs to take account of the access issues when you have a pandemic and a disaster like this, that you need to respond more urgently so that the public health response is better informed. Where we didn't do well is obviously the PPE, and I think that's well known. But I think it's important to say that here, we had a quality assurance and procurement system for PPEs that was not robust. A number of provinces historically prior to COVID procured PPE on their own. They were not part of a national contract. There wasn't really a strong quality assurance system in place in terms of the quality of the PPE. And I think, if you have any weakness in your health system, you can be sure that COVID will basically make that into a massive problem, simply because those are the weaknesses in the system. So as a consequence of that, you can anticipate that there were shortages around PPE. There was poor quality PPE as well coming through, because the regulatory system wasn't that tight, and there were procurement irregularities, and I think you've seen a lot of that playing itself out in the media. What's interesting is that it's in sharp contrast to what you would see on the medicine procurement side, right? Where you'd see that the quality is assured, you don't have problems with medicine quality, you have a national tender system, and you get globally competitive prices. And so the question really is, so what's different and what works, and how can PPE learn the lessons of what happened in medicine? So some of the key lessons for PPE clearly is that the procurement needs to happen through a regulated system. At a national level, the system for procurement needs to be put in place with the appropriate contracts, and the quality must be regulated at a national level. We left, for example, the quality assessment and to a provincial level, where provincial departments really don't have the capacity to do that. Well, even in the private sector, they also had similar challenges. And then the procurement system to then allow each province to negotiate and establish that on their own is a massive problem. There were also problems around the logistics, largely because this was happening in 9 different provinces, and sometimes it wasn't even happening at a provincial level, but at a facility level. So there are a number of lessons of what not to do here. In terms of facility readiness, I think our response was largely influenced psychologically, at least, from the experiences that we saw globally, where you had people not having access to hospital beds, on the streets, getting oxygen and the like. And And that, I think, really caused a lot of fear and panic amongst all of us, because we really didn't want a repeat of that, particularly when you see that in many of our more developed countries that have sufficient resources. So with this global experience, we had anticipated that we're going to have to establish far more beds than what we had. And I think some of the modeling exercises informed that in the initial stage as well. That's the data we had at the time, and we had to basically act on that. And so we anticipated this real tsunami of cases, and the nightmare that we would have patients that were not going to be able to get beds. And so over a short period of time, we had to basically establish field hospitals. I think that the assumption at the time as well was that those patients that are non-COVID that would ordinarily occupy our beds, the assumption was that they will continue to occupy beds for those conditions, without appreciating that what was going to happen was we were going to have a decline in those numbers. People were fearful of going to hospitals, and so many of the hospital beds would then become available that could be used for COVID. But this is all what I'm sharing with you in hindsight as such. There are some very excellent responses around the oxygen side of things. Our oxygen suppliers came to the party. Our initial assessments around oxygen suggested we were going to have a serious problem, but after working with the oxygen companies and some of the consultancy firms like Deloitte, etc., we were able to mitigate this quite well. Even a very good news story around ventilators. The usual producers of ventilators were unable to supply. The developed countries had bought up all of the ventilators. Mr. Trump had basically closed off any ventilator supply to any other country. And so our local manufacturers did really well in putting together a ventilator project coordinated through the CSIR and the Solidarity Fund, put in a lot of funding for that. And so I think, we came through really well on the ventilator side of things. And I think we're very well stocked at this stage, if I can put it like that. On the information systems, we had a minimal patient information system before COVID. It was very rudimentary, and we were forced to put together, clinical information of patients to understand what's going on, what the picture of the epidemic looks like from a clinical perspective. The DATCOV system that our colleagues at the NICD were able to put together was an amazing task, and that linked up with the private hospital systems gave us a very good picture of what was going on fairly quickly. And that was also another very good lesson about how we could just, through interoperability, bring together a number of information systems quickly without having to spend too much money on these things. The COVID alert app, where we worked again here with the private sector and put together this alert app, the one that uses Bluetooth technology, so it alerts you when you may have been exposed to a person who was positive for COVID. And then even on our laboratory information side, we would not be able to provide the statistics that we are on a daily basis if both the private laboratories as well as the NHLS were not able to combine their data and provide that as a single feed, which on a daily basis we're then able to report on, which was really, I think, an amazing feat as well. And then as important was, as I indicated, we anticipated that we were going to have many more patients than our public sector would ever be able to manage. And so we were going to breach our public health, public hospital capacity. And we needed to bring in the excess capacity of, we were hoping at that stage it would exist. And I think our private hospitals and specialists have done very well in responding to that. We were able to get contracts in place at affordable prices. We didn't use that as much as we had anticipated, simply because we didn't get to those numbers overall. But I think it was a good experience in contracting and understanding each other as well. There were also GPs that were contracted, not as many as we were anticipating or hoping for in that case. And our private labs, as I said, did very well. All of them were providing a lot of support to the NHLS when there were challenges, particularly in test kits as many of the wealthier countries that bought up a lot of the kits, and we were battling to just access test kits. So in summary, I think, you know, our pandemic response, the COVID pandemic has certainly exposed the weaknesses in health systems globally, and South Africa is no different. We've seen all the weaknesses in our system, and those are the pointers or indicators of what needs to improve in terms of the health system. But I think we've done relatively well from the morbidity and mortality data when we compare ourselves to the global experience. So I think we need to focus largely on the health system strengthening at this stage, because that's really where the system needs to improve. And if we can have a nationally coordinated but locally delivered health system, I think we would be much better placed than we have been over the years. Our public-private contracting experiences have provided some very positive experiences, and this is an opportunity to potentially expand in other areas, particularly where the state is, has a capacity constraints. On the public procurement side, many lessons in terms of PPE about what not to do. Also, some lessons from our own procurement system on how it can be done properly. And I think just implementing those measures, having a very good and good governance system in place that prevents some of the malfeasance that has happened to date, I think will be important. And then finally, the information system, sorry, this last sentence got cut off for some reason. Information systems that currently exist can be used to establish a national system for the oversight of the clinical information of patients. Thank you very much. I'll stop there at this point.
Thank you so much, Anban, for this presentation. I noticed there's quite a few questions asked on the question and answer part. I think what we will do, Anban, if you can look at some of those questions, then afterwards, after Alex gave his presentation, we will then come back to the questions and answers, if that would be okay with you and all the members out there that is watching. Please do not put your questions on the chat, but again on question and answer part. Thank you so much. I'm now going to go over and introduce Professor Alex van den Heever. And for those of you who doesn't know Prof. Alex van den Heever, he is currently holds the chair of Social Security Systems Administration and Management Studies at the University of the Witwatersrand. Prof holds a master's degree in economics from the University of Cape Town and has worked in the areas of health economics and finance, public finance, and social security in various capacities since 1989. This includes participation in the Malamet Commission of Inquiry into Medical Schemes in 1993 to 1994, the Taylor Committee of Inquiry into Comprehensive Social Security from 2000 to 2002, and the Ministerial Task Team on Social Health Insurance from 2003 to 2005. Prof. van den Heever has also held positions in the Department of Finance, like a Central Economic Advisory Services, the Industrial Development Corporation, the Center for Health Policy at the University of the Witwatersrand, and the Gauteng Department of Health. From 2000 to 2010, he worked as an advisor to the Council for Medical Schemes, which he was partly responsible for establishing together with the regulatory framework, and in an advisory capacity to the Social Security policy process, including the Department of Social Development, National Treasury, the Interdepartmental Task Team on Social Security, taking forward the recommendations of the Taylor Committee and the Competition Commission regarding private health markets. Then, if that is not enough, Prof. van den Heever has also published extensively in the field of health policy, the implementation and review of health public-private partnerships, and the regulation of health systems. What a mouthful again. Now, over to you, Prof. Alex van den Heever, and let's listen to your presentation. Thank you so much. If we can just unmute Prof. Alex van den Heever, will help.
Apologies, I thought I was unmuted. Okay, right. So I'm going to be covering two areas in this talk. One is the sort of an overview of the COVID response and the COVID experience, and what it might imply for our health system. And then I will talk to a degree on the sort of NHI and certain of its implications, and review the the appropriateness of the proposals going forward, certainly within the next 3 to 10 years. So part of what I'm going to present is an analysis of sort of a technical review of some of the data and what it may imply for what has actually happened. And I think this will be important in understanding what went right and what possibly went very, very wrong in this COVID response that we've experienced. So the first issue, there's been some discussion of this, and I'm going to go through each sort of major area of the sort of COVID response. One is the testing strategy. And the reason for raising this is that the private testing strategy is, private testing levels have consistently outperformed public sector testing. And this raises quite a few questions about exactly what our response was. It essentially meant that we had a schizophrenic testing and tracing strategy from the get-go. So firstly, with the private sector testing at higher levels than the public sector does seem appropriate, given if the private sector is not incorporated into an overall strategic response. It also indicates that we had quite a lot of capacity to test, and that the capacity in the private sector was increasing when the public sector was indicating that it was facing all sorts of constraints in expanding its capabilities. Now, the important thing is that when the prevalence levels are relatively low, testing and tracing has value in suppressing transmission in the epidemic. And we're currently at relatively low prevalence levels now, and we were at relatively low prevalence levels in March and early April. And our testing strategy wasn't scaled up to deal with that. So it's very unclear as to why we did not have an overall coherent testing and tracing strategy as one of our key early responses, and also why it's not a key frontline response now. So there was no combined public-private strategy, but the private sector was able to escalate testing while the NHLS tended to face bottlenecks. So this raises questions about why we were facing bottlenecks in the public sector when we weren't facing them in the private sector. So there is an important issue as to what our strategy should be now prior to a possible surge in April, May, which I will talk to a bit more, but I think that there's this talk consistently about the sort of so-called second wave, second surge, and a second surge is actually quite probable in the South African context, but the question is when. So the epidemic does tend to demonstrate a strong seasonality, and that is potentially because of human behavior, not necessarily because of the virus being killed by UV rays. And that means that when winter begins, we will probably start finding we've got a problem again. So we've got to both suppress the epidemic during this period where people tend to be outside and in better ventilated areas, but we also need to be prepared for the situation as we now see it in Europe when conditions get colder. And that's the period over which we experience the epidemic. And the question is, what role does testing and tracing play in our strategy? And it's still not clear. So now I'm going to talk a bit about what the epidemic trajectory potentially meant. So this is all the provincial new infection trends from level 5 all the way to level 1. And what this shows is that there were different peaks in the different provinces. So there's a sequential spread spatially through time that appears to be uncorrelated, unrelated to the lockdown levels. So the lockdown levels don't appear to have any impact on the trajectory of the epidemics. They appear to be following a trajectory all of their own. And what it appears is that if we've got the sequential movement of the epidemic through time, it does suggest that there is a movement from one province to another province. Now, this might seem counterintuitive if the epidemic began and was seeded in all of the provinces pretty much simultaneously by people on international travelers. So what we should have seen if the lockdown was particularly important in preventing or suppressing the epidemic is we probably should have seen epidemics starting at roughly the same point in time in all the provinces and then peaking and then declining potentially. And I'll talk to that decline also, what potentially caused that as well. But it's the sequential movement suggests that the provinces were communicating. In other words, people were moving and causing super spreading events from one province to another. And they were particularly going into the more vulnerable communities for transmission in very populous metropolitan areas. And this would be, and we have a movement from Western Cape to the Eastern Cape to Gauteng to KwaZulu-Natal as the major areas where we have metropolitan, major cities and metropolitan areas. I do not think that it's not confirmed, but it raises the question as to whether or not the lockdown had any impact whatsoever on the trajectory of the epidemic. And this, I think, is an important consideration when we consider a lockdown as our frontline response, our first response to dealing with an epidemic such as this. So I would say that this trajectory suggests that the lockdown had no effect whatsoever on transmission. And there are other factors that suggest the same factor as well, including why and when we peaked in each of the provinces and why they tended to occur at particular periods. Was it because we prevented it through our non-pharmaceutical interventions, or was it because we reached herd immunity in local communities? And it appears that the evidence strongly suggests the latter. And there are big implications if that is the case. So the next issue is to bring into account the excess death information. And this is the situation for South Africa, and I've got a number of pieces of data indicated in this figure. The first is I've got in red here, the reported COVID-19 deaths. This orangey area is an adjustment to the deaths based on the assumption that the Western Cape's reporting of deaths was the best of all the provinces. So effectively, their infection mortality rate was used to create this correction. So it moves to that point. But when we consider the excess deaths, we get this blue area. And the new infections are the black dotted line. And what's important about that is how correlated the new infection data is with the excess deaths. Noting that excess deaths come to, at this point, this
Alex, we lost you there. maybe just quickly go out and log in again.
We will try and get Prof back as soon as possible.
Thank you. Alex, are you back? You are muted.
Hi. Sorry, have I on twice? I'll share the screen, sorry, again.
Thank you. You were just started to discuss this when you were off.
Okay.
Regarding the blue line.
Okay, so the blue area are the excess deaths. The black dotted line is the new infection rates. So this is the national picture. And what you see is that the new infection rates, they're on two different axes, so that they show, if the shape is very similar, it shows you what they're correlated with. So this suggests a very high level of correlation between the new infection rates and the excess deaths, whereas the correlation between reported deaths bears no relation, very limited relation to the new infection rates. So this strongly suggests that the excess deaths are actually COVID deaths. When we look at the an R-squared, so this is the correlation coefficient for new infections, regressed against the excess deaths, and it has an R-squared of 0.975, which means it's extremely highly correlated. They appear to be the same. So what this suggests is that our excess deaths are potentially an accurate reflection of our COVID deaths. And if that is the case, it has huge implications for what's happened in this epidemic. And that has not been part of the narrative or discussion to date. So a further issue is what we've seen, and I'm going to go into the excess death information at a provincial level more to show the implications. But what it appears from the seroprevalence studies is that in certain highly populous communities, we've had seroprevalence rates of between 31 and 46%. And when you take into account those are the sort of levels that are very close to achieving herd immunity. And that suggests, as this comment does from the NICD, that the community infections are likely to be a main contributor to the decline of COVID-19 in the Cape Town metro. And this is pretty much reflected in the other metros. In other words, we've had herd immunity in these in the local epidemics in these very concentrated areas, and that is potentially the cause of the decline in the epidemic that we've seen, rather than prevention. This suggests that South Africa did not materially prevent many infections during this winter. So the reported infections by week 14 October was 658,000. Based on these mortality rates, if we had to assume excess mortality is the true COVID mortality, then we probably had around about 2.8 million infections by that date in South Africa, in contrast to the 658,000 actually reported. So there's a question as to whether we can rely on the sort of new case data by province. We could potentially rely on the trend, although the absolute numbers are unlikely to be true. And I think that this is pretty much everywhere around the world. And errors will relate both to underreporting, that means we just don't know, and asymptomatic cases who don't come forward for testing. So the international evidence suggests around 20%, although the sort of common modeling assumption in South Africa usually is about 80%. So long as the testing strategies remain broadly constant through time, the trend should be comparable. The trend should be comparable, even where strategies differ by province. But I think it's important to note that there's not enough public data available to compare testing strategies. It would be really nice if there was more information made public on these issues. But let's look at the provincial breakdown. So I've just shown the national correlation to excess deaths. But a further confirmation of this is to look at the picture provincially. So this is the Western Cape. So focus on the blue area and the black dots, as with the national. So you can see in the Western Cape, the correlation is also very close as it was with the national picture, although the Western Cape's trajectory is quite different to that of the national trajectory. And when we do generate a correlation coefficient through a linear regression, we get an R squared of about 0.92, which is very, very high. So that means that there's an extremely close correlation between the excess deaths and new infections. And it's very unlikely that you'll get such a close correlation unless the infections were a cause of the deaths. So here's Eastern Cape, a completely different shape to the Western Cape. And yet when you look at the black dots versus the blue area, the correlation is again very close. Sorry, one more point about the Western Cape. If the excess deaths are 7,090 and their reported deaths are 4,104, then they have effectively reported 58% of their actual COVID deaths. If we look at Eastern Cape, excess deaths amount to 12,000 on my estimate. The reported deaths are 3,069, or 25.2% of the excess deaths, a very low percentage, much lower than the Western Cape. But the correlation between the black dots and the blue area is very close. So if we look at the R squared, the correlation coefficient, it comes to 0.96. It's even higher than the Western Cape. So this suggests very strongly the excess deaths, again, are COVID deaths, but on a different trajectory to that of the Western Cape. If we look at Gauteng, very similar picture. The black dots versus the blue area, it's in fact a different trajectory, different timing of the peak and everything to the Eastern Cape and the Western Cape, and yet it is very closely correlated. Excess deaths here would be by that period of 16,000. They've reported 4,000 only, and that's about 25% of the excess deaths. Correlation coefficient is in Gauteng is 0.97, very, very high. KwaZulu-Natal, very similar picture. The correlation coefficient is 0.944. Excess deaths would be 10,000 versus reported deaths of 2,500. So only 25.1% of the potential COVID deaths are reported. In the case of Mpumalanga, we get 12.5% of the excess deaths. They've reported 495, and yet excess deaths are 3,949. Correlation coefficient is, there's a smaller population in Mpumalanga. Correlation coefficient is 0.81, still very high. You can see the shape is very similar. So this again does suggest in Mpumalanga completely different timing to Gauteng, Western Cape, Eastern Cape, and yet a close correlation between infection levels and excess deaths. Similar picture for Northwest, correlation coefficient of 0.866. And they have, if this were accurate, they reported deaths on 9.8% of excess deaths. Limpopo, again, very similar picture. Their R squared is 0.8. Excess deaths 3,300, reported deaths 353, which is only 10.4% of the excess deaths. Free State, similar picture, nearly 0.9%, very close correlation, very similar shape. Northern Cape, very small population, excess deaths are 1,360, reported deaths are 353, which is 13.5% of the excess deaths, but it has a low R squared, and that's potentially because Western Cape has very small numbers of new infections and deaths. So when you put all of that together, not only does the national new infection levels and excess deaths correlate very, very closely, but so do the provincial trajectories. And that, I would argue, is very unlikely unless these were COVID deaths. So it appears as though it is very unlikely that the excess deaths that we are seeing are collateral deaths. In other words, because people can't access healthcare services. These are COVID deaths. So, but what are the implications of this? Let's have another look at some of the other data. One thing that has been very difficult during the process of this epidemic has been to get information on what's going on at the treatment level. The private sector has provided reports. I've received some of those, and they've provided them to the NICD as well. And that's the brown line you're seeing here, which is the number of inpatients in the private sector. But you're seeing something quite unusual. What you're seeing is in the red line are public sector inpatient information, is public sector inpatients all the way through the epidemic, including the peak period. And what it suggests is that the private sector has had more inpatients than the public sector all the way through. So this is from the ADCOV data. This appears highly improbable. And it's also problematic that the public sector occupied beds, just the shape of the trajectory of the occupied beds is poorly correlated with the epidemic. It has an R squared of 0.062. That means very, very little correlation at all. The private sector occupied beds are actually very closely correlated with the national epidemic at 0.73, which suggests that the data is potentially accurate. But the public sector beds information can't be true. So either the public sector patients did not get to hospital or they were not reported as COVID-19 patients, but there's something wrong here. And all of this is from the NICD data. Now, if we reverse engineer the excess death information and try and work out what our occupancy should have been over the period of the epidemic, we get this picture, which shows that, in fact, we should have had a huge number of inpatients if that was our excess death information, because we do have quite a lot of international comparative data on the ratio between new infections and deaths, and between new infections and inpatient utilization. And based on extrapolating from that, this is sort of roughly the picture we should have. And the reported information is a sliver down here. The green is the private sector data, and below it, the dotted line is the public sector reported information. But based on the excess death information, we should have had public sector need was probably this blue area. But somehow they didn't come to hospital. They weren't tracked. This is, I think, very unusual and suggests a huge gap in our surveillance, potentially, or in our facility readiness. Did these patients just not get to hospital? Were they turned away? What happened? So another interesting picture, when we look at the capabilities of our provinces as part of an assessment in our response to this epidemic, you can sort of cross-map our maternal mortality ratios with the consistency of COVID-19 death reporting. And just to note that I've been building up with various proxy indicators of capability within the health system. And what you want to do is use proxy indicators because we don't have a very good data set on performance of our public services. So you kind of have to look at indirect indicators or other indicators that are suggestive of performance and capability. And if I use those percentages of the excess deaths, the reported deaths expressed as a percentage of the excess deaths, assuming that the excess deaths are an accurate reflection of COVID deaths, you get an idea of potentially of capabilities. The assumption being that a poorly performing province doesn't actually do its surveillance very well. And a well-performing province does. Poorly performing province doesn't actually, has more maternal mortality, higher levels of maternal mortality than provinces who are performing better. And this is the picture that emerges with this assessment. The Western Cape ends up with the lowest maternal mortality ratios, and also it has the highest percentage of reported deaths expressed as a percentage of excess deaths. And we have this bunching over here, Eastern Cape, KZN, Gauteng, and we have a bunching down here with the rest, which all had very, very low estimates. And I'd say that that, to me, is very problematic. It's suggesting that there are significant problems in the capabilities of our health system. In the discussion on NHI, I don't think this points to us creating some sort of ESCOM to solve this problem. This is very much an issue of how we're managing the service, the governance structures we put in place on a decentralized basis within our health system, how we make sure that people do their job properly. And if we take a look, I would not dismiss the PPE experience as if this was some aberration because somehow the procurement structure wasn't properly set up. That is not a valid assessment. The Western Cape, again, did not have the levels of PPE corruption that the other provinces did. What it suggests is that many of these provinces are predisposed to corrupt conduct, and that when the opportunity arises, they leap into it. And that is a very fundamental flaw in the way in which our organizations are being operated at present. It's about the conduct and the capabilities of the departments and the conduct of the individuals within those departments and how they've got there and how they've been retained in that position. That, I think, is a huge issue, and that is quite clearly not being addressed in policy at all at this stage. If we look at the other indicators of outcomes, Auditor General's outcomes for provincial departments mimic this. They show this. Again, Gauteng, 5.9% of their overall provincial expenditure is irregular expenditure. This is from the Auditor General. Mpumalanga, 5.3%. Northern Cape, 6.7%. Eastern Cape, 1.2%, amazingly. Free State, 11.9%. KwaZulu-Natal, 9%. Northwest, 8.2%. Limpopo, 4.1%. Western Cape, 0.1%. What this would suggest, if I were investigating departments, is that there is institutionalized corruption here. You can't get this level of irregular expenditure just through incompetence. This is deliberate. People don't believe that they're going to get caught. So a further issue going into the COVID experience was our distribution of beds and how we understood our position. The private sector has more critical care beds than the public sector. Some form of sharing of services between the sectors was clearly indicated in March. Only 7 public, as far as I'm aware, only 7 public sector patients require treatment in a private facility. It's odd that, because I think that the services should have been overwhelmed if the excess deaths are a true reflection of the epidemic, a truer reflection than all of the surveillance information we're being presented at this point. The agreements were finalized only in the Western Cape, again, and the idea was to cut and paste them in the rest of the country because, in fact, neither national nor the provinces had the capacity to actually enter into and expeditiously developed coherent contracts and sharing arrangements. And countries like Chile got their whole story sorted out in March. They didn't wait until June, July, August. So the other issue is that to solve the problem of the disparity, the Western Cape also had field hospitals erected in time for their surge. In Gauteng, field hospitals were not ready. By the time of their surge, there wasn't oxygen being supplied to them. They were the wrong beds. There were no staff for them. It hadn't been properly thought through. And now we have a contract running through till January, despite the fact that they're over their surge for now. And it's questionable as to whether the field hospital approach is the best way to go going forward. Now, going back to the issue
Excuse me, Alex.
Yes,
Alex,
yeah.
excuse me. Can you maybe enlarge your presentation for so that I can, it's such an interesting presentation, but it's a bit small. Can you enlarge it? Is it possible?
I can't really, it's on a full screen here. Which one are you looking at though?
The small one, the 2020 financial, 2021 financial year changes. You've got two screens. You've got the next slide. Maybe if you remove the next slide.
Oh, I think it might be just how I've, maybe I need to.
If it's possible. Otherwise, it's fine, Alex.
Okay, I'll just reshare, sorry.
Maybe you should switch off the presenter view.
Yeah, okay. It's a question as to whether I can choose the, just 1 second, I'm going to.
Yeah, that's better.
Okay, are you seeing the big,
Yeah.
screen? Okay, I'm sorry for that.
Thanks so much for this, thanks.
Okay, in the 2021, this is basically an assessment that I've done of the loss of GDP that we've experienced based on the second quarter GDP figures that came out. And this takes into account that we will rebound in many sectors. So this is an annualized picture of how much GDP we've lost per sector. So overall, I'm estimating about 8.2%. That's within the range of quite a few estimates. The construction industry lost 18.8%, they're still losing. Wholesale and retail, 16.1%. Manufacturing, 15.7%. Transport, storage and communication, 12.4%. Mining and quarrying, minus 8.4%. Government, at the bottom there, lost 0.2%. Finance and real estate lost only 3.4%. So we have this huge impact on key sectors, which is very, very problematic, and some of it is still ongoing, including within the hospitality industry. So this is a devastating impact. And here the question will really be at the end of the day is whether or not the lockdown should be the preferred option for addressing an epidemic such as this, because the effect of this has produced about a 7-year impact on our economy. And I'll talk to that just next, but we're not going to easily recover from this over time. And much of this loss was incurred in the first 21 days of the level 5 lockdown. And the question is really, did we get value for money for this catastrophe? This is the position that has just been produced by National Treasury in the supplementary budget. This shows you two scenarios for our debt to GDP ratios, government debt to GDP ratios. This shows you that we're effectively looking at this year getting to about 81.8% of GDP. That's accumulated debt. They've got a so-called passive scenario, which takes us up to 140.7% of GDP by 2028. Now, that scenario, by the way, is just completely catastrophic. It's important to note that even in this financial year, government was struggling to borrow the money to finance the current deficit. And going forward, the crisis is going to deepen year by year, which means that if government is not in a position to manage its expenditure going forward without undermining the economy, we are going to be in real trouble. So by this period, we're going to be, this is 2023, 24. So a few years just before the so-called implementation of NHI, we will go to 106.1% if we're lucky. Sorry, if we're not lucky. If we're lucky, we will only be at 87.4%, which is worse than this year on an actively managed scenario. Now you can see how National Treasury is looking at a scenario from 2020 to 2028. That's the scale of the impact that we're facing. We started 2019 at 63.5. So we've leapt up this point. So the level 5 lockdown cost South Africa about 13 billion rand per day in lost economic output in the first 21 days, which was already enough to undermine government finances for the foreseeable future. The active scenario for managing government debt assumes that government expenditure on salaries and wages can be reined in, and that the failing state enterprises can be rescued without further bailouts, which is quite obviously, from what we are seeing, far from certain because they are being propped up. So unlike the position of large industrialized economies, South Africa may not be able to finance its deficits with further borrowing, and the scope for raising taxes is virtually nil. So the 25 debt service costs will consume around 31% of the main budget revenue. Effectively, SA will be borrowing to pay debt service costs. That's the position we're in, and that's usually referred to, we're now on the precipice, on the point of being in a position where we've got a debt spiral. So just some overview of additional issues and some additional issues on the COVID crisis. In my view, the management of the local epidemic appears dislocated from the domestic context. You do not just borrow strategies from other countries. You've got to take into account the domestic context. Whether or not the UK or Germany chooses to go into a lockdown does not imply that South Africa should follow suit, because they're in a position at the end of the day to stimulate their economies out of any crisis. They're also, as with the United States, in a position to survive a much higher debt to GDP ratio than South Africa can. We're a small open economy and people just lose confidence in us. And if we can't borrow the money to finance the deficit, we have to finance it by printing money. When we do that, we get hyperinflation and a collapse of our economy. So the economic harm of the lockdown was substantial, but did not appear to add value to reducing the epidemic. And that is very important, because if we are going to use any kind of approach, such as a lockdown, then it's actually got to address the epidemic we have. Quite clearly it didn't. That sequential movement of the epidemic through the country suggests the lockdown had no impact on the movement of people between regions within South Africa, despite the fact there was supposed to be no interprovincial movement. The epidemic appears to have declined principally because of localized herd immunity in highly concentrated metropolitan settings, not our public health interventions. They may have had an effect. Generalized mask wearing, people working from home, that definitely had an effect on people not getting infected. But of our vulnerable communities that find it difficult to socially distance, they have been hit very badly and effectively got to the point of herd immunity, which means you didn't succeed. The surveillance of the epidemic relied on substantial cooperation from public and private sectors, but only the private sector and the Western Cape appear to have performed. That is deeply problematic. Only something like 16% of the public sector hospitals have participated in the NICD collection of hospital inpatient data. That's just crazy. How can we not get our public sector to provide inpatient data to the NICD? There was no national testing strategy, and the private sectors consistently outperformed numerically the public sector, but there's also no strategy. We can get to levels where we could get a potential preventive effect out of our strategy, but without a strategy, we're just passively testing people. So it's unclear where all the public sector COVID patients were treated, or if they were treated, because we have no data and information. So the surveillance system is a failure. The levels of corruption strongly indicate a poorly governed public health system, which stems from institutionalized systems of patronage made possible through the absence of any legal barrier between political office bearers and the officials responsible for delivery. That's why we are seeing such high levels of corruption, because the door is opened by people at the top of the system, not people taking advantage at the bottom. So I think that's sort of my overall assessment on the sort of COVID epidemic. And I'm going to run through some issues around national health insurance briefly, because my key concern with national health insurance is it doesn't address anything substantively that talks to the capabilities of our public or private health systems. We have effectively done nothing to reform the institutional framework of our health system now for nearly 20 years. We've done nothing. And we have not addressed the obvious flaws in the system. We've left them in place. And that the institutionalized patronage in the public sector, the failure to actually regulate the private sector, which is one of the findings of the health market inquiry, is a government failure. and it's continuing. So with that, I'm going to sort of explore, I think I don't want to go on, maybe not all of the issues on the sort of NHI discussion, but I want to talk to a number of issues on the rationale for the proposal itself. And I think that this, to me, is deeply problematic given where we are, both from COVID and the delivery up until the beginning of 2020. Is that the rationale for the proposal can be broken down. You need to ask for a rationale for the three key recommendations. It says it's got to solve a pooling problem, it's got to have a purchaser-provider split, and that purchaser must be a monopoly purchaser. And it's important to note that whereas there is definitely evidence for improving pooling in the health system in South Africa, both within the public and the private sectors, there is no evidence that we are going to benefit in terms of our governance framework from either an institutionalized purchaser-provider split as our only arrangement, or by making that purchaser-provider split the creature of a monopoly. Monopolies do not work well. As we've seen in South Africa in numerous cases, they don't work well in the private environment, they don't work well in the public sector. So I'm going to talk to some of the issues just with in terms of the overall structuring of NHI, given the current context. This is how our current system is arranged. We have a general tax-funded arrangement where pooling of health finances occurs at the national level. We allocate down to provinces through conditional grants and provincial equitable share formula, transfers equivalent to 33% of provincial revenue for the health services. It's important to note that this 33% of provincial revenue is a mechanism that was introduced as a substitute for provinces having to raise their own taxes, which is a very complex matter. For provinces to have to raise taxes to raise their own taxes, and then to equalize across all the provinces between provinces like Gauteng and Mpumalanga and Eastern Cape is an incredibly difficult exercise. It would require what's referred to as a tax capacity equalization system, a form of risk equalization for taxes raised by provinces. But the Constitution allocates these powers to the provinces, and it assumes that those powers involve the ability to finance these policies, which include health services. So that's a clear power that they have. They can raise taxes, they can legislate, they can deliver, they can do all of those things. They've got immense powers to do all of those things, and they should be using them. Those powers are allocated by the Constitution, and this financial system of allocating money to the provinces through the provincial equitable share and the conditional grants is not a gift by national government to the provinces. It's a substitute for the tax capacity equalization mechanism. It's raised through national taxes and then allocated down, mostly as unallocated money for provinces to budget. And it's done so because it's in lieu of tax revenue. Now that is constitutionally required, because if you take it away, then the provinces must raise the taxes themselves. So this is so part of the NHI framework, which I'm going to just jump through because it will just take a bit too long, is this becomes one of the key problems, because the key idea of the NHI framework is that it is going to crash this particular system. In the case of the medical scheme system, part of our universal coverage model is that we have a tax credit arrangement which allocates a per capita amount per person covered if you're on the schemes, and that prevents higher income earners from getting more out of that tax credit than low income earners. And that is the government's, so between tax-funded healthcare services and the tax credit, this is used to pay medical schemes and to provide part of the subsidy in lieu of medical scheme members not using state services for which they are required to pay. And they have been required to pay for many, many, many years. And that's the reason for the tax arrangement, is that if they need to have insurance to be able to afford to pay for a public facility if they use it. So the tax credit is in lieu of the in-kind benefit provided to people who use the state. So this is our current universal coverage model. So this means that this is part of the rights framework that exists in terms of Section 27. So the NHI proposals, all the red areas are what they plan to eliminate. Those transfers to the provinces. They want to remove the powers for the organisation and financing of healthcare from the provinces, remove the tax credit, and the benefit and access guarantees, effectively through medical schemes, because the idea is that your minimum benefits will now be obtained through the National Health Insurance Fund, not through a medical scheme. So as a consequence, they will allow medical schemes effectively to risk rate people and to not provide basic minimum benefits. So this would be the final framework. So this is part of where a great deal of difficulty arises, because the proposal for NHI suggests that it is going to completely restructure two pre-existing decentralized systems of funding and providing healthcare, one on the medical scheme side, the other in the provinces. And we'll create a third system that doesn't exist, and we're going to assume that it is going to be well managed and to work better than the one in the past. The proposal also does not involve introducing any kind of separation of political office bearers from the delivery part of the organization. So it centralizes procurement, it centralizes licensing, it centralizes contracting, the actual sort of delivery arrangements. And what we've seen with state monopolies that end up with these politically appointed organizations is that they fail not only because of the centralization, but also because of the political appointments. And there appears to be no attempt to change or move away from this model, no interest in moving away from, despite the fact the evidence is before us in terms of the impact on the COVID crisis. People without the proper governance arrangements steal public money, as they've done with COVID. So there's a further issue that part of this argument is that it's based on human resources unfairly distributed in the state. There's definitely a difference in per capita expenditure, but the human resource distributions are, let's say in the case of 2011, an assessment between public and private human resources showed that 71.9% were in the public sector, 28.1% were in the private. So this was the case in 2011. Since then, we've seen 49.2% increases in professional nurses up to 2016. That's the data that's made public. Staff nurses have increased by 47.5%, medical practitioners by 50.5%, ambulance and related workers 61.1%, medical specialists by 34.5%. So the issue here is that the private sector doesn't keep human resources out of the state. If the state is able to employ them, because the state's salaries are incredibly good. And when you take into account the government employs pension funds arrangements, which is effectively the equivalent benefit that you'd have to accumulate within the private sector, the lump sum that you'd have to accumulate is many millions in order to get an annuity the size that you get out of the GPA. It's an extraordinarily generous package on the state. So many people are quite happy with it if they prepared to accept the working conditions. So the issue is the private sector does not constrain the movement of people into the state. What constrains the movement of people into the state is the way in which the state is managed and how it prioritizes its services. I'm going to very quickly go through this because the rationale for NHI around those three areas, pooling, purchaser provider split, monopoly purchaser, is actually never defended in any kind of policy appraisal anywhere. So the issue is that over an 11-year period, we have had no technical assessment of the different policy proposals, the discrete policy proposals, the pooling, the purchaser provider split proposal, and the monopoly purchaser. Those are three discrete elements that require a complete feasibility assessment to see whether they are appropriate and they will work. Because of time constraints, I won't go through this, but there is no analysis of this, including the financial feasibilities. So the question is, how will this arrangement be funded? We've seen the position of finances now. We've seen particular people responsible for this policy proposal saying they only need 33 billion by 25-26, and at most 55 billion over and above the 20 billion currently spent in the public health sector. So this is because the state is already spending on the provision of comprehensive services in several facilities, blah, blah, blah. So the idea that somehow national health insurance will buy all the services in South Africa with 33 billion is completely nonsensical, 55 billion. But even the raising of 33 billion or 55 billion by 2025-26 is inconceivable at this point. So, but it's interesting to note that there has been no proposal. The argument now is that we shouldn't even have a financial feasibility analysis of NHI. Now, given the current finances of the state, quite clearly a financial feasibility assessment is required, but a financial feasibility assessment is not a costing analysis. I'm going to jump through a couple of these just for time's sake. This just shows an indication of the current tax credit versus the per capita expenditure of people in the public sector, and the subsidy has been adjusted so that it is lower than the per capita expenditure on people in the public sector. So this is not kind of financing profiteering or financing individuals in a privileged environment. This is basically a subsidy for not using the state. So if we had to take away, let's assume that that tax credit was removed. The current public sector budget, this is a year or so ago, our public sector budget was 22 billion. The covered population in the public sector is 48 million. Per capita expenditure is 4,583 at that point. An NHI scenario with 30 billion more, and there's no change in the public sector population, would only have a 13.6% real increase in expenditure. But if we have a dropout because of the removal of the subsidy of 1 million people, it will only be an increase of 11.3%. If 2 million drop out, it becomes 9.1%. 3 million drop out, it becomes 7% only. 4 million drop out, 4.9%. And 100% drop out, there would be minus 4.3%. So the issue of collapsing coverage in the private sector is extremely problematic if the state is not in a position to actually take up that coverage. So I'm going to run, I think it's important to note that this was our tax basis prior to COVID. And the idea that we can just increase taxes to finance NHI in the foreseeable future is just bewilderingly stupid. It is just impossible. The way in which tax systems work is that you tax particular tax bases up until the maximum capacity. It's often referred to as a Laffer curve. So the higher the tax rate goes, beyond a certain point, tax revenues start to decline with higher and higher tax rates. So this assumption that you can just increase a tax rate and get more revenue doesn't work out. So that's why you do a financial feasibility analysis, because the idea that you're going to be able to take money from medical schemes and put them into the state depends on whether or not you can raise taxes that create that substitution without hitting the Laffer curve problem. Well, I'm afraid they're going to hit the Laffer curve problem because that's the way it works with general taxes. And there will be no increase in government revenue and no substitution of expenditure between the public and private sector if you just by increasing taxes. So if we had to look at a full NHI scenario, that doesn't even provide full coverage, it would require about 3% of GDP to be raised. This is completely inconceivable in the foreseeable future. So if we go back to this picture that I showed earlier, this is when NHI is meant to be implemented at that period in our fiscal position. So it's unclear what fiscal scenario is actually anticipated as a basis for NHI implementation. And it's important to note that over a period of 11 years, the NHI process has been unable to generate a financial feasibility assessment of the NHI framework. The Davis Tax Commission indicated that a large degree of uncertainty and lack of common understanding of how the NHI will be implemented and operated is of concern, given the magnitude of the proposed reform. Given the considerable size of the projected funding shortfall, substantial increases in VAT or personal income tax, and or the introduction of a new social security tax, would be required to fund the NHI. Magnitudes of the proposed NHI fiscal requirements are so large that they might require trade-offs with other laudable NDP programs, such as expansion of access to post-school education and social security. So given the current costing parameters outlined in the white paper at that stage, the proposed NHI in its current format is unlikely to be sustainable unless there is sustained economic growth. Well, we can see our position in terms of sustained economic growth. And it's worth noting that in a review in 2005 of the NHI proposals, which only did an NHI analysis as part of a general scenario analysis, concluded that national health insurance, even with a minimum benefit costed at the lowest level feasible, appears not to be affordable in the medium term. Overall, health expenditure would rise to exceed 11.3% of GDP. With minimum benefits to be more comprehensive, the increases in overall health expenditure would be significantly in excess of this figure. So these are the financial positions, and this is why you do a financial feasibility analysis. But this is the position that this is the position of the former Minister of Health. He indicates that after 9 years of work at that stage, he added that the budget for the NHI is yet to be confirmed, and that initial estimates of 256 billion were thumbsucked by a local accounting firm who made a mistake on the figures. I then went to the World Bank and the World Health Organization and now asked, why am I trying to do this? Can't be quantified by any human being because the costs are so variable. This, I'm afraid, is just unacceptable. So, I'm going to leave it at this point. There are sort of more comments, but I don't want to carry on too late, but I think I'll just sort of conclude with some general comments. And I think that the point about health sector reform is strategic health sector reform occurs on an incremental basis. It requires a fundamental understanding of the position we're in now and where we need to move next within our capabilities. What we don't need as a reform approach is to have a sort of a grandiose proposal that is unachievable, and for all the time of government to be spent wasting their time on trying to retrofit a proposal into some option that can't be realized in our lifetimes, when we should be looking step by step at our reform options going forward. We have so much that needs to be changed in the public and the private sectors. There are many, many proposals that have been developed to date. They are still on the table. They need to basically be implemented and taken forward. And we don't need to centralize the provinces. We need to change the governance frameworks in the province. We don't need to collapse the private health system. We need to regulate it properly. And the proposals are there to do all of that. So I think that what we've seen from COVID is that our health system is not properly prepared. And moving forward, even into a crisis, it is inappropriate to adopt ad hoc measures to deal with major crises. We need systems, and systems require proper design, proper consideration, sustainable approaches, and a very, very careful understanding of what our capabilities are at this point. And to date, we have not done that. And I think that we still have, and there's still going to be a lot of digging into what we actually did in this COVID response. And I would argue that it has been far from acceptable as a strategic response for South Africa. And we still do not have all of the information made public that would be important to understand the position that we're in and what we need to do next. I will stop there.
Thank you so much, Alex. This was really a thought-provoking presentation. And yeah, that's, you know, I'm not sure what to say after this excellent presentation again. So what we're going to do, I'm going to ask Shelley McGee, who is the head of our Knowledge Management Department, to moderate the questions that has been asked on the question and answering platform. And Shelley, if you can start with that, and afterwards, I would then ask Dr. Mzukwa, our Vice Chair, to then end the session, and thanks everyone. And the reason why I'm asking Dr. Mazukwa, or already make you aware of Dr. Mazukwa, is I've seen there's some glitches on our Zoom platform tonight, and I don't want to end up not being able to introduce Dr. Mazukwa at the end of this meeting or the end of the question and answering session. So Shirley, it is over to you. And please, I see there's a lot of questions and answer to be answered. It's about 40 that I can see, and there's 7 on the chat. I'm not sure whether we would be able to address all of them. Shirley, it's over to you. Thank you so much.
Great. Thank you, Dr. Coetzee. Yeah, there have been a lot of questions posed, I think, during both talks. What I'm going to do is sort of prioritize the questions in order of their relevance, I think, to our main topic tonight. So there are a lot of technical questions here that I think potentially might be best posed to epidemiologists, and neither Dr. Pillay nor Prof are here for epidemiologists. So I'm just going to start with the 2 certainly that have come up that I think are most relevant to the topic this evening. Anban, during your talk, one of the questions we received was, what, in your opinion, what lessons were learned in terms of the structures that have been suggested for NHI? So in other words, this relationship between central control to the actual operations and implementation at a local level. What, in your opinion, have sort of been the learnings from your dealings with the COVID outbreak?
Thanks for the question, Shelley. I think it's important that we recognize that COVID is an infectious disease, obviously, and our response linked to an infectious disease and how we would deal with that relative to other non-infectious diseases may be different. So when I respond around this issue, it may obviously need to be adjusted when we're talking about other conditions, how we manage that. But I think in this context around COVID, one of the most critical things that we needed was information, and information around the number of patients that are infected, the testing strategy. I think Alex spent a lot of time being critical of it, and it is correct that we needed to test many more people than we had tested. There were a number of challenges about why that didn't happen in the public sector, but I think those need to be fixed. So I think that would be key, together with the contact tracing, so that we can identify cases much earlier and not get to the stage where there's a full-blown epidemic at your doorstep, and you haven't had an opportunity to respond to it until you get to that stage. So I think that's critical. I think the information systems, I think the data that Alex was talking about around the excess deaths and the discrepancy, and the discrepancy is largely linked to the fact that many of the provincial systems were not linked to the DATCOF system, and it took a long time for them to get the IT systems to talk to each other, if that's a good way to describe the IT problem. And now I think all of the facilities across the country are linked electronically to the DATCOF system. So clearly there was a difference in the number of patients reported that were occupying beds, etc., at various points, largely because the public sector facilities were not supplying data into the system like the way some of the private facilities were. So I think that's a key aspect of the COVID. On the negative side, relating to the procurement, I think in our NHI proposal, we've made it very clear that we think procurement of goods, for example, need to happen at a national contract and provincially purchased. So in other words, there'll be a national contract if you're talking about PPE, so that at a provincial level, you will simply buy off that contract. That prevents a number of the problems that you would have if you allowed at a local level people to get involved in the level of assessment, each one doing their own tender, each one then doing their own assessment of quality, etc. It creates a number of problems. You also don't benefit from a large purchase in terms of a discount, etc., on the price. So I think those are some of the NHI lessons that we certainly would want to take forward. Thanks.
All right, thanks, Anban. Then I guess the next most relevant question that came out and it's sort of a reverse question, I guess, to both Dr. Pillay and Prof van Heever. What were some of the things that you think could have been done differently in handling the pandemic? I think we've sort of explored some of these issues already. And what that related to was how or what in terms of diagnosing the existing challenges and then turning this into sort of designing workable strategies that can actually be used to try and achieve universal health coverage. This is not specific to NHI, but it's trying to make these things more universal. So Alex, can I ask you to respond there?
Some of the things that are in the, look, responding to an epidemic like this depends on kind of patching together platforms that don't necessarily exist on a routine basis. So they depend on existing capabilities. You're connecting up with provinces, you're connecting with private sector, you're connecting across government. In a lot of my discussions with people within government, they were extremely dissatisfied with the platforms that were set up, were excluded from decision-making processes, were totally unclear about the evidence that was being used for many of the decisions. And the processes were very murky. But what one would want to do in a proper process is a couple of things. Let's take an example on public-private cooperation to share services and facilities. That's testing, contact tracing as one key strategy. The other is access to services. And what should happen is that there is a very transparent platform that is created for immediate decision-making that solves these problems very immediately. But what it looked like was that government essentially created a screening mechanism in which decisions were made somewhere else. And it actually hamstrung it, reduced the capabilities of many public-private platforms, and people were just left confused as to what was happening. So a combined strategy on testing and tracing requires a platform that actually sets it up. Same with contact tracing. We now have a contact tracing app. When the first surge is over, the next surge is probably going to be in winter again. But it took us until now to get something. We should have had that in March, April, at least something. So when it's very difficult to know exactly what platforms were designed and what didn't work. But in speaking to a lot of people, the problem was the inability to actually set up workable, efficient platforms that could solve and deal with problems very, very quickly. And I think that would be one of the urgent things to do. The other important issue that South Africa does need to do is to localize quite a lot of capability, general capability, which is for testing, the production of key pieces of equipment, reagent material, things like that, so that we don't have to depend on international supply lines or friends in China. We've actually got to be able to do it ourselves and do it quickly. So I think that those are some of the things that one would look at.
Thanks. And Anban, because the question was to both of you, are there some things that you would have seen done differently in terms of if we had to sort of achieve a universal platform in this instance?
Well, I think I've shared some of those. I think getting a good information system in place would be critical, and I think that would be one of the key things I would want to do. The second is informing the public about the importance of behavior change and getting a more effective strategy in place, because I think if we can reduce the transmissions, all of the other issues fall into place. And how effective we are in getting a behavior change strategy in place is key. We took a long time to get people to understand that, and if there were more effective means of doing so, I think that would have been key for us. Yeah.
Then thanks. And then we also got a couple of questions with relation to COVID Connect and the COVID Alert app. So and these were directed at Dr. Pillay. So in terms of COVID Connect, the question we received there was, are there plans to augment this existing platform in preparation for, the second wave? And that would mean to enable contact tracing. And then we also received a comment with regards to the COVID Alert app, sort of actually more a complaint that it's really, it doesn't seem to be of much use at all, because it simply is an alert about a contact, but doesn't really give any information as to where that contact happened. So I guess the question from both of those, the doctors there was, are there plans to improve these platforms going forward?
Well, these platforms were designed to achieve a balance in terms of protection of personal information and anonymity, etc. So some of the so-called flaws in the app are deliberate because people don't necessarily want others to know where they've been, etc. And so that's the reason why you wouldn't get geolocation information or who it is that you're in contact with, etc. The app, the design of the app has largely been global in nature in many cases, and that has been adapted to obviously the South African environment, but has protected some of those personal issues. So that's why you find that it will not tell you who the person is that you're in contact with, or which place it was, etc. Because it's not important to have that information. What's important is that you potentially were exposed to somebody who was positive. And then you need to manage the situation based on that. So sharing who that person is would create a whole host of other problems. And so globally, the decision was that that information shouldn't really be shared.
All right, thanks for that. So I think along sort of similar lines, and also with regard to data, we also got a question, and I think this has been partially answered. But there's a second part to this question as well, is why were the hospital numbers so slow in coming forward? And then number two, why were they so closely guarded, and why is this information, and I think this refers to a real-time basis, why is this information still so difficult for doctors to gain access to? So
well, the information was slow into the central repository simply because there was one national system in which we were wanting all of the facilities to provide their data into. And they were not able to connect their systems into that system for a range of IT difficulties or challenges. And that took a long time to resolve and required a number of teams to do that. Eventually it did have, well, it's happened now, and it took a lot of effort on our part to get that done. And so clearly the reporting around that would be slow simply because the number of facilities reporting was low and required time before that was increased. So, but being closely guarded, I'm not sure what that's about, but I mean, all the data was in the NICD and they were on a regular basis putting out reports. So I'm not very clear about what that actually means.
Okay, well, maybe the questioner can clarify that and I can sort of bring it up again. Prof, on Heever, the issue around excess deaths, there were quite a few queries around that as well. Now, I mean, this is a question that I think we'd have to probably pose eventually and not now to the MRC, but for the excess deaths, there was a question about, do we know yet what the common cause of death then was noted on the death certificates? I don't think that was necessarily how this was, looked at from the MRC's point of view.
That's correct. The excess deaths at this stage are just the overall natural deaths, and this is the deviation from the normal death trend. So that curve that I'm showing is highly correlated with the trajectory of the infections, and that suggests at this stage, without factual confirmation from the death certificate as to what the cause of death is. Cause of death information comes out with a huge lag from Home Affairs, and Stats SA will report on that, and probably SAMRC. But even with the cause of death data, you may not get a COVID a COVID death reported in that. It might be something else. You could die of a heart attack and they were not tested for COVID. So the deviation which was used in many countries, the actual deviation from normal deaths, was used to check the reported data in a number of countries. The deviation in those countries and the difference, let's say if it was the UK, it showed that there was a lot of deaths not being counted, but they were, for instance, in nursing homes. And so those deaths were picked up there, but the difference between the excess deaths and the reported deaths was much less than in South Africa. So it does suggest a problem. I just want to comment on the DATCOV situation. I mean, my concern is that immediately the reporting on the hospital inpatient data was, the system was set up. The Western Cape reported with 100% of its hospitals. The private sector reported with all of their hospitals, 100%. But the rest of the country did not report. So the total public sector hospitals reporting is about 16%, counting the Western Cape hospitals. So the question is, why did the Western Cape manage to get on the DATCOM system so easily and the rest of South Africa didn't? And it does point to huge capacity problems around the provinces for some reason. And that's where it comes, the discussion on governance again becomes important.
Okay, thanks. And then in relation, we also received a question about public-private partnerships, specifically for diagnosis purposes. So this was again to both of you. So I'll let Anban address this first, but what measures do you think can be implemented for a possible second wave to ensure that perhaps the resources are better shared in the diagnosis space?
So currently we have a joint reporting system for COVID diagnosis between public and private laboratories, and the provincial departments of health at a provincial level have a Prof joints, which includes the private sector colleagues responsible for contact tracing, testing, etc. So the coordination at that level is intended to address whether a person was tested in the private sector or the public sector should actually be irrelevant. It should be important to identify the person and his or her contacts early and make sure that they appropriately manage so that there isn't further transmission. That's the key to the matter, and shouldn't really be where the test was done as such, because whether you diagnose in the public or private, it's going to have the same consequence overall.
And then Alex, I don't know if you've also got a comment. It was posed to both of you.
Yeah, the only issue I'd say is when we expect the risk of a second surge to occur. I think it's very, very probable that we would have one going into winter, which means that from April, May, we should be in full prevention mode. We've got an indirect prevention system in place now, which is a behavioral response to being in hot weather. And there's natural better ventilation if you're outside. We were not, through our messaging, managing the ventilation risk and the super spreading risk at this point. The other is we're not fully engaged. We're not aggressive in our testing and tracing strategies as well. There's some contestation on whether testing and tracing should be our core strategy and whether it will actually work at the end of the day. But we're certainly not very aggressive, and we are not combining the public and private sector as part of a strategy. It should go beyond reporting. It has to be as part of a strategic prevention strategy for both testing and tracing. And the question there of the relationship between the national contact tracing platforms and provincial contact tracing platforms is unclear. There should actually be a very, very rapid national contact tracing platform integrated into what provinces are doing. But it appears that very much provinces are doing their own thing, and institutions and organizations are doing their own thing. And that's not a strategy. You allow people to continue with their strategies, but you've got to have an overriding strategy that is really driving an aggressive campaign. And I'm not sure that we have.
All right, and now sort of into the more controversial, I guess, questions. This was posed to Anban. There were numerous reports that the advice from the Ministerial Advisory Committee was overruled or disregarded by the political leaders. Was this actually the case, or was it fake news?
Well, I don't know about what fake news means, but if the advice that the Ministerial Advisory Committee provided is published on our website, and the actions linked to it are also on the website. So that's clear to see. If you look at that advice, you would see that over 95% of the advice was actually adopted in some or other form, whether it's guidelines or the like. There were issues that the Municipal Advisory Committee provided advice on, which was not agreed, and that advice was not adopted. And so I think at the end of the day, if the Municipal Advisory Committee was going to provide advice and there was an obligation to adopt that advice, then the Municipal Advisory Committee is no longer an advisory committee. It is now becomes the de facto Minister of Health or the like. So we need to make sure that those that make are responsible for making decisions do that and are held accountable, obviously, as a result of that. What you can't do is set up an advisory committee and then say every advice that they provide I'm going to adopt, and if I don't adopt that advice, then I'm going to be attacked for that, and that's going to be a problem. And I think that's problematic. We need to have an approach where those that are in office make decisions. If those are wrong decisions, obviously there are consequences for those wrong decisions, but they need to make those decisions. We can't have a municipal advisory committee that's making decisions on behalf of those that are responsible for the health system.
Can I comment on that just briefly?
Yes, please, Alex.
Yeah, I mean, I think the point that has been raised by quite a few people isn't that the Ministerial Advisory Committee or any advisory committee should be making determinative decisions for government. The idea is that they are providing technical and evidence-based advice, or advice in which they're providing an expert view, even if the underlying evidence is weak at that point. To the extent that government differs from that advice, it should explain why it differs. That's, I think, the core complaint that many people have at this stage, is that essentially people made discretionary decisions without explaining their decisions, and that differed from advice given from the advisory committee or any other expert advisors. So the point is, government does need to be held to account. It can differ, but it must also explain its decisions, and it wasn't. And I think that involved creating a lot of mistrust in the decisions that government has taken.
And still along that theory, or that line of sort of questioning, one of the attendees basically has said, you know, all of these objectives, observations, and the data demonstrated by Prof and Heever, it's difficult to sort of look at informed policy making when there's a seeming or clear lack of accountability, the necessary requisite skills, and just ballooning irregular expenditure. So in terms of the implementation of UHC, what are the plans in place to improve governance? That's to Anban, I presume.
Yeah, thanks for that question. So it's an interesting argument. I mean, Prof. Heever's concern with NHI is that you're taking away the provinces. You should rather leave the provinces in place and put in place a better governance structure, is his argument. But as you can see from the question that you've just presented to me, the problem is not necessarily the governance structure. It's the structural arrangement about way things happen. For example, Prof. Heever had a problem with the way provinces are reporting in on the DATCOV system, which is his concern of ours as well. So how do you manage that? Do you put in a better governance system to manage that? I don't think so. I think you need a better structural system for managing that, and you need to have central coordination and local level implementation, and that's what needs to happen. And so I think in this particular case for UHC, we've made it quite clear that we think that a centralized funding system with local level implementation for service delivery is what we need, so that you don't have many of these problems that we've had now. No system is perfect. I think that system will have its own challenges as well, but I think there'll be we'll be in a better place compared to where we are now, certainly.
Prof, have you got any comments to add there?
Yeah, I think that we should be careful of false equivalencies on different arrangements. So first of all, as I pointed out in the DATCOV system, why did the Western Cape get it right and all the other provinces not? So that suggests a governance problem in the other provinces in the Western Cape. It also suggests that resolving the problem is potentially local. It doesn't mean that in a simple matter, like collecting surveillance information, that there isn't a degree of very strong central coordination with local collection. It does require that there's a standardized reporting system. So the standards of reporting should be created. The mechanisms should facilitate. But data collection is one thing. Running services that are accountable to communities is another. That you don't treat in the same way as you do when you buy drugs centrally. That's a completely different, much more complex system. Plus, holding those services to account, clinical governance frameworks that report downward. Right now, we still have, even within a provincial system, highly centralized mechanisms in which the population is completely distant, completely separated from how those services are run. They can't hold anybody accountable unless they sue them.
I'm not sure I agree with the way Alex has presented his response, but anyway, I think let's go on. It's quite late in the night.
And I mean, yes, so I mean, I think this will be the last question then to both of you. So, I mean, this has just come in now on the question. So what are the critical elements then that we can learn from the Western Cape if their performance appears to have been better than the other provinces? So I'll pose that to Alex first and then to Anban, and that'll be the last question.
Well, I think that it's very clear in a number of indicators that the Western Cape is performing at a structurally different level to all the other provinces. There's a whole range of proxy indicators that will show that. I would say that even the Western Cape's performance can be improved with improvements in key governance frameworks. But what is really key is, first of all, separating political office bearers from the delivery of services. That has quite clearly polluted the performance of the systems. It pollutes it at a national level. It doesn't matter whether you're dealing with a state monopoly or a public hospital. That's why Eskom has collapsed. That's why Transnet has collapsed. That's why all of these services and functions are failing. They're failing for that reason. They don't have to be provincial services to fail. So one thing is getting that right. And there appears to be no political will to actually put that in place. So that's a very key one when we've actually, we've designed essentially our public health system and structures for what can be regarded as a low trust, a high trust environment, when in fact we have to have the governance systems for a low trust environment. We effectively trust the discretion of all sorts of people that we shouldn't trust, and we need to change that. So I think that's one of the things that we need to do to change the system.
All right, Anban, then I'll give you the last word on that question.
Yeah, I think that, you know, overall the Western Cape has resources that many other provinces don't. If you go to the Northwest, or you go to the Northern Cape or Limpopo and Mpumalanga, the skills that you would be able to get to support you in a response to COVID is very different from what you would get in the Western Cape. So to simply compare the Western Cape to any other province without appreciating the historical differences between the provinces and how they were structured over time is problematic. So I think it would be much more appropriate to understand what resources provinces have and whether they've had the best effort in responding to COVID, because in many cases people have tried, but they just don't have the capacity to do so, either in the types of skills that they need or the resources to do so. The funding for healthcare across the provinces differs quite significantly. Many of them are in high levels of accruals, etc. So it's not easy for them to simply move in the manner that many other provinces have.
Right, thanks so much. I think with that, we'll close. It's getting late. I'm seeing people are dropping off the webinar. So Dr. Mzukwa, I'm just going to ask you, thank you. And we've been getting comments all the way through, by the way, Prof and Dr. Pillay, saying thank you for brilliant presentations, I think, on both sides. So thank you very much to you both. Dr. Mzukwa, if I can just ask you to close for us.
Thank you so much, Shelley. I'd like to really thank Dr. Anban Pillay and Prof. Alex van den Heever for the excellent presentations and the deep insight that they presented to us. Our Dr. Angelique Coetzee, the Chair of SAMA, and the Board of Directors for their guidance. How can I forget the head of office staff who worked, behind the scenes to make the event very possible. All the members, the loyal SAMA members who were part of this evening, and all our medical doctors who are esteemed professionals who are not yet members of the association, for tuning in on both Zoom and the YouTube channels. We truly appreciate, and we hope that you have a wonderful evening with your families and wherever you are. We'd like to thank you very much for this opportunity. Thank you. Good night.
Thank you and good night, and hope to see you all on the next webinar. Thank you. Bye.
Bye.
Oh, thanks.